Thank you. Good afternoon, everyone. I'm Anurad Baminiwatta, and I believe our study is quite well aligned with the main theme of our sessions, Healing the Trouble During Troubled Times. It's titled A Randomized Control Trial of a Mindfulness-Based Online Intervention to Reduce Stress and Improve Well-being Among Healthcare Workers During the COVID-19 Pandemic. Let's first look at the background that led us to conceptualize this study. Globally, there was mounting evidence on the preponderance of mental health issues among healthcare workers, and meta-analyses estimated, for example, the prevalence of depression and anxiety to be close to 40%. In Sri Lanka, even higher rates were reported at certain centers, and at our center in Colombo North Teaching Hospital, we observed in a study that preceded this trial that more than 1/5 of the healthcare workers exhibited significant levels of psychological distress. So there was a tangible need for an effective, feasible, and acceptable intervention to safeguard the mental well-being of healthcare workers. Mindfulness-based interventions have a large evidence base supporting their efficacy. And we know that mindfulness is a concept and practice that is quite close to our culture. So we believe that a mindfulness-based approach would be acceptable to the target community. And however, mindfulness-based interventions had not been evaluated in a randomized control design or among healthcare workers before in Sri Lanka. And also we opted for the online format because of its many advantages. We know that online interventions are more accessible, participants can join in from their own environments, and they save the time and cost of traveling as well. And also during the COVID-19 pandemic, the restrictions on physical gatherings also made this the more preferable approach. So we set out to evaluate the effectiveness, feasibility, and acceptability of an online mindfulness-based intervention in reducing stress and improving well-being among healthcare workers. Our protocol was pre-registered in the Sri Lanka Clinical Trials Registry, and ethics approval was obtained. Our participants were recruited from 3 tertiary care hospitals in Sri Lanka. Our participants were healthcare workers of any category, aged 18 or above, and able to access internet at home. However, we excluded those who could not understand Sinhala, those who were receiving concurrent psychotherapy and other forms of psychotherapy, and those in whom psychiatric treatment had been commenced within the last 3 months. Shown here is the consort diagram of our participant flow. Our sample size was 80, and we randomly allocated these participants into 2 groups as the intervention arm and the waitlist control arm of 40 each. And the intervention arm went through the intervention over 6 weeks, while the other group served as the control group. And thereafter, the waitlist control group also went through the same intervention. If you look at our intervention, it was mainly an adaptation of the mindfulness-based stress reduction program developed by John Kabat-Zinn, but with elements of mindfulness-based cognitive therapy and compassion-based practices as well. And each week, the group gathered for an online session lasting for 1 hour. And over the next week, the participants were encouraged to do home practice of mindfulness-based exercises at least 20 minutes per day. The primary outcomes that we assessed at the beginning and end of the trial were stress, as measured using the perceived stress scale, and well-being, as assessed using the WHO 5 index. Additionally, we also assessed the acceptability and feasibility of the intervention. We tested the effectiveness of the intervention using ANCOVA models in both intention to treat and complete case analysis, and the corresponding effect sizes were calculated. Shown here is a comparison of the socio-demographic characteristics in the 2 groups, and we found that the 2 groups are similar with regard to the socio-demographic factors, and there was a female preponderance in the sample, and also the sample mainly consisted of nurses and doctors. Now coming to the main results, you can see here in this diagram the effect on well-being. So there was a marked improvement in well-being in the intervention arm compared to the control arm, and this difference was statistically significant. On intention to treat analysis, this translated into a medium effect size, whereas on complete case analysis, this meant a large effect size. Then with regard to the effect on stress, you can see a reduction in stress levels in both groups, but with a steeper reduction in the intervention arm. However, this difference did not reach statistical significance. On both ITT and CC analysis, this was only a small effect. If you look at the feasibility and acceptability of our intervention, the median number of sessions attended by participants was 3, and at the post-evaluation, out of the 22 who responded, 21 said they liked the intervention, 22 said the meditation recordings that were made available were very useful, and 21 said they found the techniques easy to practice. One of the main questions that arose from the findings was, why did well-being improve without a change in stress levels? So there could have been several reasons. One thing is, we know that well-being is now conceptualized as a positive affect state rather than mere absence of negative affect states. And also we know that other mental health problems like depression and anxiety could have contributed to well-being. However, in our study we have not assessed whether depression and anxiety changed over the trial. And also in our 6-week intervention, the fifth week was spent on developing self-compassion, which we know is linked to well-being. So the proximity of the compassion-based practices to the post-evaluation could have contributed to these differential effects. One of the main strengths of our study was that it was adequately powered with an adequate sample size. And however, there were several limitations that we may need to address in future research. The sample was overrepresented by females, and the retention rate at the end of the trial was rather limited, and also depression and anxiety were not assessed. And finally, mechanisms of action, why well-being improved, could not be established in our study, but that was particularly because we didn't have validated instruments to assess certain constructs like mindfulness and self-compassion at the time of conceptualizing this study. So in conclusion, our online mindfulness-based intervention was found to be effective in improving well-being among healthcare workers with a medium to large effect size. However, the improvement in stress was not statistically significant. That concludes my presentation, and these are some of the references I have used.